Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And once again, this is your show, so you ask questions and we try to get you the expert answers. So today we're going to be talking about things related to pain and physical therapy and different methods to deal with pain. So we have an expert right in front of me. We have Dr. Jonathan Kamerlink, who is an anesthesiologist and an interventional pain specialist, and he, I would say, is the main link in the Kamerlink Pain Institute in Boca, correct?
Yes, sir.
Welcome.
Thank you.
Good to have you.
Pleasure to be here.
And then we have Kelby Kaplan, who has many acronyms after her name. But she's a doctor of physical therapy, and I know many other things which you'll tell us. Mm-hmm. And you are one of these people that I admire, that go on and on and on and seek additional education to improve what you present to your patients. Mm-hmm. So welcome.
Thank you for having me.
Good to have you. Dr. Kamerlink, we were sort of chatting before we got to this set about the items which people who view us are very, very interested in. And you know, one of the things that they specifically are interested in, and I told you early on, is the minimally invasive surgical techniques. And why? Because they want to deal with the resultant elements of less cutting, less blood, less pain. And then we started to talk about pain. And that's your area of expertise, in quotes. And I think it's very important for them to understand how we could, in today's world of delivering healthcare, mitigate a good amount of the pain.
So interventional pain is methods that I use, and there's many of us out in the country that practice in the same way, that we do procedures basically to help alleviate people's pain in a relatively less invasive way as compared to surgery, that enables people to enjoy their activities of daily living that are appropriate for their age.
And when you say that, appropriate for their age, I will tell you that we get a lot of comments from people. Don't forget, we have an active, we're blessed by living here in Florida, mm-hmm. basically South Florida. A lot of people enjoy their swimming pools, they enjoy their golf courses, they enjoy their tennis courts. Not that they own them, but the availability. They play, adult as well as younger people playing baseball, football, flagpole, everything, the whole spectrum. And we have a lot of sports injuries down here, what I would call weekend warrior injuries. And pain is also part of that community of interest. So why don't we just talk about that all in general?
So let's say a young, healthy 35-year-old guy comes to see me, and he has back pain, leg pain, colloquially called sciatica, probably because of an acute disc herniation. I would expect him to return to what his normal activities were prior to that injury. Let's say he swims, he plays golf, he runs 3 miles, he plays with his kids, so on and so on. The expectations of, let's say, a 35-year-old are going to be very different than someone who comes to see me who's 80. And that's one of the things I always talk to about my patients for the first time on their visit is expectations of treatment. What do I realistically expect for them? Now, let's say an 80-year-old person who walks with an assistance of a walker, I don't expect them to have the same outcomes as that 35-year-old. I want them to get to the point where it's appropriate for their age. They will walk around, play cards, go swimming if that's what they were doing before they came to see me. It's what's age appropriate, and that's a very key word. We have to have realistic expectations, and I think that's a big problem in American society is that we don't have realistic expectations. There are people who are 70 and they want me to make them 20 again. I tell people all the time, I don't have the fountain of youth. I can't make you 20 again. If I did, I'd have a line from here to the Florida state border. But that's not realistic. I can alleviate their pain. I can make it tolerable. And again, I focus on that word tolerable because, again, people want me to make them 100% pain-free. Whether it's a chronic condition that's affecting them, they've had some type of surgery and they have acute pain ailment after surgery. Again, I tell people it's all about realistic expectations and making your pain tolerable. I tell them all the time, if someone can guarantee you to be 100% pain-free, those are the people that you should really worry about and be concerned about, because those people are more likely to hurt you than what I can do.
So, Kelby Kaplan,
Yes.
I would assume that that good quality physicians like Dr. Kamerlink work with physical therapists and occupational therapists and people who are what I would call a part of the rehab team. So tell us what your involvement is in the world of pain.
So physical therapy can help in similar vein in that our goal is to get our individuals back to their activities of daily living, what they deem to be important, and help them achieve their goals. So whether that is getting back to playing cards, moving around the house, being able to go visit their family, to travel through the airport. So we really focus on what it is they were doing before to help them get back. So we work on posture, we work on balance, we work on walking, strengthening, and getting them set up on an aerobic conditioning program so that they can have less pain and get back to what it is that they want to do. So we really try to focus on their goals.
You know, an interesting thing, you just hit on something which we here at Nova Southeastern have. Of course, you know, we have a number of affiliated clinics, but one of the most utilized and referred to clinic is the balance clinic. And the reason why is because it's interdisciplinary. We have audiology, we have physical therapy, occupational therapy, we have sports medicine folks, and what they do is they try to, and psychology, by the way. And the reason is because there are a lot of folks who have the so-called slip and fall, age-related slips and falls, walking out of a shower, tripping over a step, getting out of an automobile, and somehow there's this condition that's set around them that says you can't do this anymore. And we work with them in an interdisciplinary fashion. So have you had the opportunity to work with people like that?
We have. I've had several patients that have come here to the clinic at Nova who have visited the Balance and Falls Clinic, who've come with a full report so that they've been fully evaluated. The toughest thing with a fall and slip and fall, even if it's innocuous, as you said, is that it can sometimes start a cascade of events, because then there's fear, and then people aren't moving, and then that snowballs into a condition where then they're losing mobility, which is a long-term problem.
Do you practice in a rehab facility, or do you have your own practice, or you involved at a hospital, or what?
Well, here for the last 4 years that I've been at Nova Southeastern, I actually practice in the clinic on campus.
Right.
Prior to that, I worked at Delray Medical Center, where I was in outpatient and acute care, and I've always worked in outpatient. I've been a therapist for about 19 years now.
That's
so, yeah.
19 years, I mean, goodness gracious.
Time flies when you're having fun.
You look like a 19-year-old. Okay. Dr. Kamerlink, you know, again, I wanted not to get too technical, but I want people to understand, as an anesthesiologist and as, in quotes, an interventional pain specialist, what are the techniques? What do you actually do with an individual who comes in? How do you deal with it?
So before most people come to see me, they've done most of the recursory things. They've done physical therapy, they've done a lot of medications, anti-inflammatory drugs, muscle relaxers. Some have even tried some opioid medications to alleviate their pain. And their pain has really been refractory, and it has inhibited them from doing all these activities of daily living, much what Kelby was talking about there. And that's really where I come into play there. And really my job as an interventional pain specialist is to somehow break that cycle of pain, because pain is a vicious cycle. People get in pain, and like what Kelby said, they're reluctant to use certain parts of their body because they have pain. It prevents them from sleeping at night. We know that sleeping has a huge interplay with pain. The less you sleep, the more likely that your pain is going to become chronic, and so on and so on. So if I can break that cycle, get them engaged in physical therapy, get them sleeping better through the night, that's what's going to really benefit them. Now, the interventions that I do, the most common thing that I do is an epidural, what's called an epidural steroid injection. It can be done either in the neck and the low back, and that's done mostly for what we call radicular symptoms. The common name would be sciatica down the leg, or you can have almost sciatica type symptoms down the arm as well too, where there's some type of impingement on the neuroaxial skeleton that's pushing on the spinal cord and the spinal nerve roots that are coming out from the spinal cord and causing those symptoms down the arms or down the legs.
And obviously that pain reaction causes other, shall we say, hormonal adrenal responses, which then cause the individual to have multiple different problems, either anxiety, I don't want to call them pseudo, but in other words, conditional thoughts about having heart attacks, migraine headaches, things of that nature. Do people come in and complain about the whole spectrum?
Absolutely. The most common thing that I notice when my patients come into my office is that their heart is racing and their blood pressure is very high. And that's probably, number one, they're a little bit anxious and nervous to see me. And number two, because they're in such extreme pain, it causes the release of adrenaline, epinephrine within the system, and it causes these things of having tachycardia and hypertension within the body, which can predispose people to feel restless, to feel that they've lost hope. If you've ever had epinephrine injected in your body, people often report it's like a doom and gloom type of experience. And I'm sure that on the natural level, when people are in such pain, they probably have those symptoms as well too. So if I can alleviate some of their pain, bring their hormonal levels of various different hormones, dopamine, serotonin, epinephrine, norepinephrine, I can bring it down in their system, most likely all these things will resolve as well too.
Do you present your medical service in an ambulatory center, or do you do it within the hospital?
So I'm on staff at Boca Regional Hospital up in Boca Raton, and then also within my office I also have my own procedure room as well too, and I either do procedures within my office or do it in a hospital type of setting.
Okay. You know, you hit on something which, of course, we've sort of left it behind. But you know, we had this scourge, particularly in Florida, of the oxycodone issues.
You know, the problem with opioids is not endemic just to South Florida. It's endemic to Florida. It's endemic to every adjoining state. It's endemic to the entire country. The CDC last year presented data that over 60,000 people overdosed from opioid-related type of substances. I'm willing to wager that number and figure is probably much higher, of deaths that we didn't know about that were unreported, and it's been steadily increasing over the last several years. And it's really sad to see what's happened. This has probably been in the mix for the last 30 years. We've been slowly getting to this point. You know, there's a time and a place for opioid medication, and unfortunately it was just used as a general medication in the management of chronic pain. And the reality is, it's not a great medication. I do prescribe it. I'm not scared of it. I just know what the data is, and it's not really a great medication to be used for the management of chronic pain. Where I do use it quite often is for cancer-related type of pain. People who have some type of terminal cancer illness, have weeks, if months to live, and need some medication as an adjuvant along with other pain medications to help control their pain so that they feel comfortable whatever remaining days of their life that they had. The flow of opioid medication in general in the United States has dramatically decreased. I see major supply issues here in South Florida. Most of the pharmacies are either not carrying it, the insurers, and on top of that Medicare, are not covering for long-term prescriptions. Our governor just signed a bill saying that he does not want physicians prescribing more than, I believe it's a 5-day supply of opioid medications unless there's special dispensation saying that it's either a chronic condition refractory to all other medications or it's cancer-related type of pain. And even the individual physicians that are prescribing the medications is limited to either pain specialists like myself, neurologists, or physical medicine doctors.
Kelby, Kaplan, tell me again about, I know that you're involved here at our sports medicine clinic here.
Yes.
And, you know, we have so many people that are referred to us from venues. We have a lot of folks that are referred to us from Boca Regional, and many of the other wonderful hospital, I guess, opportunities that we have in South Florida.
Actually, in the state of Florida, we physical therapists now have direct access for 30 days. So what that means is that somebody can come and see a physical therapist and be evaluated and treated for 30 days without having to see their physician. So that gives us a greater reach as far as helping people, and so people don't necessarily have to go to the doctor, get the prescription before they can come to us. So hopefully they could get in a little bit sooner, which ultimately would have a better outcome.
Well, the only thing is that I want to make a point on this because I feel very strongly about this personally, and I shouldn't be because I don't editorialize on the show, but I think you just hit on a point. But people ought to know that when they come to the sports medicine clinic and rehab center here at NSU and at other places around the state, that it's interdisciplinary. So what happens is, it's not like you know, you come in and you see a physical therapist. Period. You get evaluated. You have the boarded sports medicine physicians that are there, et cetera, et cetera. So I wouldn't want Dr. Kamerlink to think that they can just walk in and that no one else is seeing them.
No.
But I think that the people out there, and I pointed to Dr. Kamerlink, but I know the folks out there ought to know that there is this collaborative sports medicine venue which has all of the various health professionals that are there to deal with the patient, correct?
Correct. All patient care should always be collaborative and interdisciplinary, and nobody really functions on their own, especially physical therapists.
The world of healthcare is changing. It's become much more collaborative.
I think that with the new technology that's coming out, I think that healthcare is going, like you mentioned before, it is going through a major change. How we practiced medicine 30 years ago is very different than how we practice now, and I'm willing to wager in 30 years from now will be dramatically different than we are doing right now. You know, within healthcare, everyone is very specialized at what they do. I'm a pain specialist. I think I'm pretty good at what I do. I'm not a radiologist. I don't pretend I'm a radiologist. Yeah, I look at all my patient scans. I look at the MRIs. I have a different perspective on things because I know my patient. I know what their pain symptoms are. I'm always trying to correlate what their pain symptoms are to what I'm seeing on the diagnostic imaging. So I always review all of it, but I'm still not a replacement to my colleagues at the radiologist. I send all my patients to professional radiology groups to have scans done, they're read by professional radiologists, and I don't dare infringe on their territory. But on the other hand, we can still collaborate. Whenever I have issues with, let's say there's a scan, I'm a little concerned about something, patient's telling me something that's going on, I see something on the MRI that, again, because I know the history of the patient, I might call my colleague radiologist and I'll talk to them on the phone, explain what the patient's symptoms are, say, I see something a little funny on the MRI, do you mind taking a second look at it again? They're happy to do that all the time. I think that those interactions show that it's all about continuity of care. The patient had an MRI, they're coming to see me in the office, I'm trying to figure out what their pain generator is. And that's a big problem within pain medicine, and I think that was a big reason why the opioids were on the rise over the last 20 years. Patients, when they come into your office and they say they're in pain, people just don't have pain just because. There's always an underlying reason. I would think at least 50% of my patients, there's a true underlying reasons. I think the other 50%, there might be a psychological cause of their pain, that they're manifesting it in a physical nature. But when you have those dialogues between the primary care docs, your radiologists, your spine surgeons, because there is a time and place to refer patients to have spine surgery, amongst myself, that provides for better care. Now, 20, 30 years ago, there wasn't great dialogue between different physicians, and I think that now that with these different EMR systems, it's relatively easy to have those dialogues. Unfortunately, all these electronic medical record systems, they don't really all talk to each other. You know, you go to, let's say, Broward Health, they have Cerner. You go to Broca Regional, they have Cerner as well too. Same program, don't talk to each other. Does that make any sense to anybody? It doesn't make sense to me at all. You know, that was the whole point in the initiative of going electronic, is so that we could have easy communication between different venues that patients receive their care. But the reality is what we don't. And there's a variety of reasons, topic for another discussion about why that happens. And those are some of the issues that we have within healthcare that we have to bridge. But the EMR systems, that's pretty much like the gold standard of how we're going to document. But we have to have those EMR systems. Number one, they have to be more efficient. I find in my own practice and many other physicians, we use a variety of EMR systems. They're not the best where they should be. You know, you take out, anybody has a smartphone now, you take out your smartphone, whether it's an iPhone or one of the Google phones or an Android phone, they're very easy to use. You can get to where you need and you can look at their maps and your email, it's very easy. These electronic medical record systems, they're not the best. They need improvement. I think that we'll get there over the next 10-year cycle. But that's a big part of how we're going to communicate between different clinicians and different venues about how patients are receiving their care.
You're so correct. I mean, EMR, electronic medical records, are really a tool for advancement of better care for the people who are watching this show. That's what I believe. Now, that's an editorial comment, but you made the comment first, so I'm using your words. I'm not allowed to do editorial comments, but you made the comment, and I'm backing you up on it. Kelby, I know that you work, like I said, you work in tandem with the other healthcare specialists, and you know the resultant element of Dr. Kamerlink, I'm sure mitigates the pain response, et cetera, but all of a sudden someone who hasn't been able to use an arm or a leg or whatever, they have to be taught to do that.
Right. Our bodies are use it or lose it.
There you go.
And so when they haven't been able to use their joints in the way that they're used to, there's a certain amount of retraining that has to happen. And certain conditions, for example, if you have somebody with long-standing back pain or neck pain, the muscles that help control the movement of the spine don't just come back because now their pain has gone down. So they need specific strengthening exercises and training in order to get those muscles to work the way that they used to. So that's a big part of what we as physical therapists do with somebody who's had chronic neck or low back pain, is remind those muscles how they're supposed to work and what they're supposed to do.
And I also know that you all work with groups that have these, what I would call immunosuppressive diseases that then end up in a situation where they lose their ability to walk or use their arms or legs. And I know you all work with them.
We do. We physical therapy actually has become quite specialized in the last 10 to 15 years as well. So now within our profession, you have orthopedic specialists like myself, you have neurological specialists, pediatric specialists. So even within our field, people are studying more and really honing their skills, which really serves the patients well, because they can see the right person for the job. So that's where our profession's going.
Well, we're down to the last 2.5 minutes of this show. So I'm going to let Dr. Kamerlink, he can offer a postulate, he can offer a sermon, he can do whatever he wants. So go right to it, Dr. Kamerlink.
A lot of people have heard about pain medicine. And pain medicine is one of the most juvenile fields of all of medicine. We've had the field basically for maybe 25, 30 years. Look at fields of internal medicine, general surgery, orthopedics. These are fields that are well established, 50, 75, 100-year-old fields. And because we're such a juvenile field, a lot of people don't really understand what you do. And a lot of what we talked about before about opioid medications, people think when they come to see me as a pain specialist, I don't usually prescribe medications. In general, I try and keep people away from opioid medications because they're really not great medications for the management of chronic pain. And I really try to steer people from medications to interventions. And basically that's the field of pain management, is that we've gone from a field of using primarily medications, specifically opioid medications, and we've done a 180, and now we are primarily in an interventional based field, meaning that we do some type of procedure for someone in a less invasive type of way to make them feel that their pain is better, enable them to do their activities of daily living, enable them to engage with physical therapy. And I agree with what Kelby said. The human body is a use it or lose it type of mentality. If you don't use certain parts of your body, they are going to atrophy, and that atrophy is going to produce some pain as well too. So I want to get people as functional as possible, using the safest things that I can possibly do in medicine, so that they're able to enjoy their good quality of life in whatever part of life they are.
Thank you. Kelby, you got 30 seconds. Go ahead.
Well, I would just want people to understand that there is a collaborative effort in healthcare, and that physical therapists do work with the team and really focus on the patient and try to get them back to what it is that they want to have in their lives and the activities that they want to have in their lives. And so it really is a group discussion, and that we have opportunities to really help and work as an adjunct with their medical care. Good.
So, Dr. Kelby Kaplan, DPT, and many other acronyms which you never got to. You're an instructor and a clinician here at NSU's Healthcare Sciences Physical Therapy Program, and associated with our Sports Medicine Clinic. Thank you very much for being here. Dr. Kamerlink, thank you very much. We appreciate your will and your desire to present not only your knowledge and care, but your attitude towards making these people out here who have talked to us about pain have a more respectful and useful life. And thank you very much.
Thank you.
Folks, I hope we answered some of your questions. I know that the issue of pain has come up a number of times from many of you. So if you have any questions or you want some answers, there's a telephone number and an email address right here. Take good care of yourself. Remember, your happiness is our happiness. So thank you once again for allowing us to come into your homes. This show is called Dateline Health. We come to you from Nova Southeastern University. And my name is Fred Lippman. Until next time, see you.